Next point is about the cysts of the pancreas. Cysts of the pancreas could be of different varieties. Congenital cysts, of course, are asymptomatic and they have very little clinical significance, except that they may be found out during some CT scan or maybe ultrasound investigations whenever they are done. Rarely, congenital cysts they may produce the symptoms of a pancreatic insufficiency, that's the reduced secretions and then hence the abnormalities of the fat digestion. But the other way, from the clinical point of view, the important are the pseudocysts. Pseudocysts are defined as localized fluid collection that are rich in amylase and other pancreatic enzymes and that have no non-epithelialized wall. See, because they do not have an epithelialized wall, they are called as pseudocysts, and they are usually a consequence of acute pancreatitis. In the acute pancreatitis, the fluid is collected, and if the fluid doesn't get infected and produces an abscess, if it doesn't produce an abscess, then that fluid may remain there and it may produce a cyst as such. Location of the pseudocyst could be either in the lesser curvature, below the lesser curvature of the stomach, or in the upper part of the abdomen, or it could be anywhere in the peritoneum, or occasionally the pseudocysts also may be extended into the thoracic area. So the cysts are formed which are having a thick membranous wall but not epithelial wall, and contains fibrous and granulation tissue, and usually appears after about a week or a few weeks of onset of the pancreatitis, acute pancreatitis, and they have to be differentiated from the necrosis and abscess conditions, and they can remain there for years together. After an episode of acute pancreatitis, a pseudocyst may remain there for quite a long time, and because the cysts are in the posterior wall of the abdomen, they are close to the aorta, and hence they produce a transmitted pulsatile swelling. So that's one of the important characteristic feature. They may produce a palpable mass in the abdomen, and a transmitted pulsation is characteristically seen. And the other clinical symptoms are many times the cysts they may not produce any specific symptoms, and whenever they produce a symptom, it could be just dull aching pain in the abdomen, persistent abdominal pain, anorexia, and the abdominal mass, a feeling of mass. Either it could be a visible mass, or at times it could be just felt by the patient that there is a mass, and when you palpate, it may be possible to palpate depending upon the size. If the size of the cyst is quite huge, it will be easily palpable, and if the size is lesser, then it may not be easily palpable. It has to be seen under the imaging studies. Jaundice or sepsis from an infected pseudocyst is a rare phenomenon, but it can occur. A pseudocyst may remain there, and all of a sudden it may produce an acute pain, and then jaundice may occur. Clinical symptoms of fever also can be produced due to the cyst in that condition. And at times, if it is infected, it can produce a tenderness in the abdomen, or there could be a rupture of the cyst, and then it may produce widespread peritonitis. Of course, fever, when any of these complications occur, fever could be another of the symptoms. Icterus, there could be a low density or low levels of bilirubin level increased, and may produce a light icterus, but might not be producing a visible changes in the clinical changes of the jaundice. Pleural effusion may occur, and investigations would be the serum amylase and lipase levels. They have to be monitored. In any patient of acute pancreatitis in the later period, you have to monitor the amylase levels and lipase levels regularly, and elevated amylase level, of course, is a sign that there could be a cyst remaining, but it's not confirmatory. But if you have a patient with a pseudocyst and his amylase levels are somewhat steady for a long time, if it is increased suddenly, if there is a sudden increase in that lipase serum amylase level, then that could be a sign that the cyst is becoming more active, or some complications have occurred in the cyst. So the utility of amylase level follow-up in a patient of pseudocyst is to see whether the course of the cyst is steady, or if there is any sudden changes in the total picture. but it may not be confirmatory about the diagnosis. See, amylase level may not be of significant utility to make the diagnosis of a pseudocyst, but if you know that there is a patient of pseudocyst and if you assess the amylase levels regularly, you can at least predict like whether there is going to be a complication or not. Then serum bilirubin and liver function tests are sometimes they may be necessary because if the cyst may produce a compression on biliary, otherwise it's not of a significant issue. Fluid analysis is another of the issue. Of course, it's not done routinely. Only when you have a suspicion about the complications of the cyst, then the fluid may be either aspirated through a needle and or maybe open surgery, and then the fluid may be subjected to CEA study to confirm about if there is a malignant changes. Carcinomembranous antigen is done to rule out the malignant pathologies, or the other physical kinetics of the fluid and amylase levels also are to be studied. And in a case of tumor, the malignancies, these amylase levels will be lower, whereas in a typical pseudocyst, amylase level would be very high in cyst as such. The more relevant would be the imaging studies. In the imaging studies, the standard criteria for diagnosis is a computed tomography, or CT is the standard criteria, because you can make out the contents of the cyst as well as the borders, the thick borders of the cyst, and their level also can be made out. Ultrasonography can help in making the diagnosis, but not the choice of diagnosis, because many times there could be missed conditions because it's in the posterior wall of the abdomen. Many times it may be masked by the fluid shadow of the stomach or fluid shadow in the intestines, and hence ultrasonography is not the benchmark investigation or the standard investigation. Though in majority of the patients, when we deal with in the routine clinical practice, we depend on the ultrasonography, which can give you an idea about the size, whether it's increasing or reducing as such. Follow-up studies it can be done. The other investigations which are done are endoscopy, cholangiopancreatography, or ERCP, but it's not diagnosis, definitely not for the diagnosis. But if at all you are planning for surgery, drainage of that, then ERCP can give you a very clear-cut idea of the possible access to the cyst, how it can be managed as such. Then MRI is not necessary for the diagnosis, but useful in detecting a solid component in the cyst, and particularly if there is a possibility of a necrosis and a pseudocyst. See, a necrotized pancreas and pseudocyst, of course, it's clinically differentiated by the acute clinical symptoms. In a patient of organic necrosis, the clinical symptoms would be acute, but the patient would have toxic symptoms like fever, whereas in a pseudocyst it's not. But there could be some situations where these clinical symptoms may not be very confirmatory, and in such a condition, MRI can help you to make out whether it's a necrosis or pseudocyst. Endoscopic ultrasonography also is not necessary for the diagnosis, but important in planning the therapy. If at all you are planning for a drainage, then it's necessary. A typical appearance of a pseudocyst would be like that thickened fibrous membrane and having no this epithelial membrane, and the whole cavity would be seen as such, a operative finding. Ultrasonography will give you the idea of the location of the cyst and the amount of the fluid over there. But as far as the presence of the solid components or absence of the solid components, it cannot be made out with the ultrasonography. CT gives you a very clear idea about the real thickness of the wall of the cyst and the consistency of the fluid, like whether there is a necrotic substance or whether there is no necrosis as such. A necrotic substance would be seen with that debris-like appearance, whereas absence of that necrotic substance, a typical pseudocyst would have a clear fluid, the consistency of the shadow would be uniform. So CT is a better diagnosis as such. Now, as far as the management is concerned, the pseudocyst would have really no acute complications, and most of the times they need not have any intervention except for symptomatic treatment. And there is always a confusion like whether to treat the cyst or not. To make out that, the Gastroenterologist Association of America has given the guidelines in 2015, and those guidelines are very important. For asymptomatic mucinous cyst, a 2-year interval is recommended for a cyst of any size undergoing surveillance, with the surveillance being stopped after 5 years if there is no change. So the guideline is if there is a cyst, every 2 years you have to monitor like whether the cyst is increasing in size or whether the consistency of the fluid inside is changing or not. If there is not much of a change, then after 5 years there is no need to follow up. It will remain as such or gradually it may get reabsorbed, doesn't need any intervention. Surgery is performed only if there is more than one concerning feature of MRI, and those concerning features are that if the size is increasing or there is a debris formed as such or there is some solid mass developing within, then these are the three important conditions what we call as the signs of maybe concern as such, and in such conditions the surgery is maybe planned as such. Otherwise, there is no need of surveillance after surgery if there is no invasive cancer. If there is no invasive cancer as such, then there is no need of follow-up after the surgery. The risk of malignant transformation of a pancreatic cyst is approximately 0.24% per year, and the risk of cancer in cysts without a significant change over 5-year period is likely to be lower. So, the risk of malignancy is not very significant. 0.24% is less than 1/4 of this percent. That means 400 out of 400 patients, one may become malignant, and this is increasing for the first year and the next year also. But after 5 years, if at all there is no change, then that complication doesn't occur, and hence the ideal management of a pseudopancreatic cyst is wait and watch without going for interference, because a surgical interference, if it doesn't go well, it can result in more serious complications. Most of the times the pancreatic surgery would result in more complications, and hence the recommendation is surgery has to be done in a center where there is a high volume of surgeries, where the number of surgeries being done are more, so that there you have a better operative skill. In the centers where the surgery is done lesser, pancreatic surgery would always result in more and more serious complications because it requires some extraordinary skill as such. That's the idea. Now, options of surgical treatment. What are the options of the treatment? Are percutaneous catheter drainage, that's the procedure of choice for infected pseudocyst, where you insert a catheter through the abdominal wall, and it's often good in reducing the size as such. It's only temporary measure, but the chances of failure are high, recurrence rates also are high, but that's a very simple procedure. Endoscopic drainage is the other way, which is also now popular, where either it could be transpapillary, that's through the endoscopic retrograde technique. You insert the catheter into the pancreatic duct and then drain out, or it could be into the stomach from the gastroscopy. As open surgical drainage is also the other way, where internal drainage is the procedure of choice. But that's not now popular. Cystogastrostomy, this is considered to be old-fashioned. So in our routine clinical management, I generally do not suggest surgery. The follow-up, of course, has to be done, and I would always recommend Arogyavardhini, Triphala Guguru and Kumaryasava, or Arogyavardhini, Adnitundya and Kumaryasava, depending upon the clinical symptoms, by which many of the patients can remain asymptomatic and have a normal life without any complications. The next of the condition related to the pancreas is chronic pancreatitis. In the chronic pancreatitis, the causes for the chronic pancreatitis is having a intraductal plugging or obstruction of the pancreatic duct, which is directly related to alcohol abuse, consumption of too much of alcohol, or a persistent habit of alcohol consumption, or stones or tumors also can produce this obstruction. So a biliary, this obstruction to the pancreatic duct, within the duct as such, either due to the residual substances, solid substances, they are precipitated, as in case of an alcoholic person, that's the sediments of the bile may get obstructed over that, or stones and tumors could also be the cause for that. And toxins and toxic metabolites also are possible. Patients who consume toxin substances as a result of the inflammatory pathology, particularly in case of acute pancreatitis, the toxic substances are released due to the autodigestion of the tissue, and that itself can result in a chronic pancreatitis later on. So acute pancreatitis resulting in a chronic pancreatitis is very common. Majority of the patients of acute pancreatitis end up in chronic pancreatitis, where either there is a damage to the tissue or there could be precipitation of the stone formation. So calcifications may occur, and hence the pancreatic duct becomes blocked or narrowed, and that results in recurrent episodes of chronic pancreatitis. The idiopathic pancreatitis, where the exact causes are not known. Now it is believed to be due to the oxidative stress. Oxidative stress in the sense of free radical theory. Free radical theory, which is something like AMA, the theory of AMA. That's due to the food which is not digested properly or which is not metabolized properly. The metabolic products, the active molecules, they may be the damaging factors. This is a comparatively new theory. The necrosis and fibrosis of the pancreas due to the previous acute episode of pancreatitis can result in recurrent acute pancreatitis that heals with fibrosis. Then ischemia, if there is an obstruction to the blood vessels, that also can result in chronic pancreatitis. Autoimmune disorders, chronic pancreatitis has been in association with the Sjogren's syndrome, biliary cirrhosis or renal tubular acidosis. In these conditions, they are well known. Pancreatitis is coexisting together. Alcohol is having a very high relationship with the pancreatitis as a chronic pancreatitis. The 60 to 70% of the patients are usually alcoholic, and 20 to 30% are considered to be idiopathic, where the exact causes are not known. The remaining 10% are due to the other rare disorders. So, in general, from the practical clinical point of view, whenever you have a patient of chronic pancreatitis, alcohol could be the most common cause, which is seen in more than 60 to 70% as such. The other rare causes which can produce a chronic pancreatitis are hyperlipidemia, patients who have significantly altered lipid concentration. Then again, if the lipid concentration is very high, like more than 1000, then the chances of a chronic pancreatitis or acute pancreatitis are quite common. Then hypercalcemia due to hyperparathyroidism, abnormality of calcium metabolism, as the serum calcium level is very high. Serum calcium level also may be triggered if you are consuming excess of these calcium molecules. That too can be a cause for that. Then nutritional or tropical pancreatitis is rare in Western countries, but it could be seen in the countries like African countries like Somalia or so on, where the nourishment is poor and the people are dependent on some other vague forms of the food substances which are not really the standard food substances, which have very extremely low calorie value like conditions. That's the area. So nourishment and the food provided also could be a cause for the pancreatitis, and this is seen in those zones where the nourishment is poor by nature. Some medications also are known to trigger the pancreatitis. The clinical presentations of chronic pancreatitis is mainly, the most important is abdominal pain, and characteristically it is presented as recurrent episodes of acute pain, and usually they are presented with the intermittent attacks of pain with unpredictable intervals. It cannot be predicted, like when the pain occurs, suddenly the patient may develop pain which may last for a few days, and it may result in a acute pain where the patient may have that pain being referred to the back with all that clinical presentation which resembles that of the acute pancreatitis, except for the toxicity. That could be the clinical symptoms of recurrent pancreatitis, the chronic pancreatitis. Many of the recurrent acute pancreatitis may result in an acute pancreatitis. See, acute pancreatitis can be a cause for the recurrent, or a recurrent chronic pancreatitis also can trigger in an acute pancreatitis. Though we use the word acute and chronic, from the clinical course point of view, these two are totally different conditions, and the approach to the management also would be different. That's all the important issue. The other clinical symptoms could be that patient may have a diarrhea or steatorrhea. Steatorrhea, quite obviously, due to the malabsorption of the fat. Then weight loss can be the other way. Anorexia also could be the other clinical symptoms which are characteristically seen. The diagnosis is The CT is more reliable where you can see the calcification or changes in the morphology of the pancreas easily. Serum amylase level is marginally raised, and the ERCP also confirms that. Pancreatic functions tests are not done routinely, only in extremely rare cases pancreatic function tests are done, and that test is done by putting a rail tube, sucking out the fluid from the stomach and intestine separately, and then assessing the pancreatic enzymes there, and the level of pancreatic enzymes there could be lower. But this kind of a test is not done routinely because it's more invasive, and only in certain very specific indications it's done rarely. So the usual routine clinical practice is CT and the amylase. In the CT, the characteristically you can make out the difference in a calcified and a edematous pancreatitis. So the status of a pancreatitis with the calcification and fibrous duct, pancreatic duct, and a simply edematous, and there is a tendency for the necrosis. Now, a chronic pancreatitis with the tendency for the necrosis has a high risk of getting converted into an acute pancreatitis, whereas a chronic pancreatitis with calcification is much safer. In that condition, the acute complications may be lesser. Ultrasonography also could be useful, but the information which you get by the ultrasonography might not be as critical as that of the CT scan. So CT scan gives you a better impression than ultrasonography, but ultrasonography also can be useful investigation to make the diagnosis of pancreatitis. Then treatment targets are, there is no question of a cure for chronic pancreatitis, except the last choice would be a pancreas transplantation. Pancreatic transplantation is a very rarely done surgery, and it's not done routinely. Very few successful cases are reported throughout the world. So from the routine clinical point of view, pancreatic transplantation is almost out of question at present. Maybe in future, when the techniques become more popular, you may have better, safer surgery. But otherwise, the present day, the treatment targets is to prevent acute complication and make the life of the patient better. And for that, the criteria would be modify the behaviors that may exacerbate the natural history of the disease, like alcohol consumption, poor nourishment, spicy food. These are the conditions which can aggravate, and they have to be avoided. And enable the pancreas to heal itself. Leave it as such. That's the most conservative approach which is suggested. And it's usually done by providing the enzymes, the pancreatic enzymes. Pancreatic enzymes are provided so that the digestion becomes normal. And if there is exocrine insufficiency, the pancreatic insufficiency is there, it has to be supplemented with the pancreatic enzymes. And if there is any acute pain in the abdomen, you may have to have a symptomatic treatment there. And the actual treatment would be pancreatic enzymes, analgesics. And the other way, another important is patients of chronic pancreatitis also have a high tendency to develop diabetes mellitus, and hence they need to be monitored for hyperglycemia. If the patients have developed diabetes mellitus, then that the treatment would be insulin. It may develop into insulin dependent diabetes mellitus. And of course, a better option and more reliable option of the treatment is Agnitundi, Aragardini and Kumari as such. Then the last part in this would be the pancreatic cancers, tumors of the pancreas. Pancreatic cancer is the 10th most common cancer in men and 8th most common cancer in women. So it's one of the significantly high incidence malignancy compared to the other organs of the body. But the outcome of this pancreatic cancer is poor, and though it is 10th and 8th in the number, as far as the cause of death due to cancers is a 4th. That suggests about the prognosis. Now this data is from the global data, wide variety of data, and it gives you an impression about the issue, like it's common, at the same time the outcome is poorer. Of course, based upon the histological conditions, histological identifications and morphological modifications, they are categorized into many categories, and you will have many varieties of them. But all these varieties are not routinely important from our routine clinical point of view, because 90% of these are ductal adenocarcinoma. remaining giant cell carcinoma, etc. These are only based upon the histological diagnosis, or at times could be morphological diagnosis, and they may have a impact on the management in terms of selection of the chemotherapeutic drug. If at all you go for the chemotherapy or radiation, the chemotherapeutic, or maybe at times it may predict the course of the treatment also, course of the condition also, depending upon the type of the tumor size, tumor types. Certain variety of the chemotherapeutic drugs may be selected. Otherwise, for the routine clinical presentation, routine clinical studies, these varieties are of not much significance. Anyway, the routine investigations, when you send a biopsy, a tissue for biopsy, the report you may get could be either giant cell carcinoma or invasive adenocarcinoma or mixed type or mucinous or pancreatoblastoma or cystic neoplasm or mucinous carcinoma, signet ring carcinoma or small cell carcinoma or undifferentiated. But the most important, most common, 90% of the patients are pancreatic ductal carcinoma as such. Now, we will discuss about the pancreatic ductal carcinoma, important because they are clinically important and you have a bit higher chance of seeing such patients. Causative factors are obesity, diabetes mellitus. In chronic pancreatitis, 40% of the patients of malignancy, pancreatic adenocarcinoma, have a history of a chronic pancreatitis which may get converted into malignancy. It is that when I say percentage, it has to be very clear. It's 40% of the patients who had pancreatic malignancy had a history of pancreatitis. It's not that chronic pancreatitis, 40% of the chronic pancreatitis develops into malignancy. It's not that way. The actual development of malignancy in chronic pancreatitis is hardly 3 to 4%. But among those patients who have malignancy, if you take the history, 40% of them would have a history of chronic pancreatitis. And there too, lifestyle factors like alcohol-induced pancreatitis would be having a high chance of developing into the pancreatic carcinoma. Then family history of pancreatic cancer also is another condition. Hereditary syndromes, there could be many hereditary pancreatic pathologies which can result in malignancy, which is around 5 to 10%. Other lifestyle factors which are well known to have a close relationship with the pancreatic malignancy are smoking and alcohol. And alcohol has 40% association and smoking 30%. The clinical symptoms of pancreatic cancer also could be wide varying. A lot, because the diagnosis is difficult because the clinical symptoms will be quite wide varying as such, and usually the diagnosis is done when the patient has clinical jaundice and a palpable gallbladder. The corrosive sign is the most dependable clinical sign in our routine clinical practice. But usually by the time the patient would have a jaundice, the size of the tumor would be quite big and it will be quite late. And once the patient has a jaundice, in case of pancreatic malignancy, it's considered to be that the outcome will be poor, which requires more rigorous intervention. A early diagnosis may be possible if you are keen about these symptoms. If a patient has a significant weight loss, mid-epigastric pain, common symptom as such, but most of the times what happens is that these symptoms are neglected or maybe misconstrued as some other issues. One of the characteristic feature of a pain produced due to pancreatic cancer is it's often seen in night time, not the daytime, and it's a very predominant complaint. A pain, abdominal pain which occurs in the night time, and a pain which is in the mid back or the lower back region which occurs at night. That should lead you to suspect about a pancreatic malignancy if the patient also has a weight loss. Then onset of diabetes mellitus within the previous 2 years. So if there is a sudden development of diabetes mellitus, pancreatic malignancy has to be suspected. And as I told you, when we see the patients in our clinical conditions, it's a painless obstructive jaundice with a palpable gallbladder, pruritus, or the other way. The other signs like Trousseau's sign and Coriolis's sign, Trousseau's sign, which is due to the deep vein thrombosis and which we have referred to in case of acute pancreatitis, also could be seen in patients. That's where you will have the venous thrombosis and the clotting over the abdominal wall. The late complications like ascites or abdominal mass, hepatomegaly due to liver metastasis also could be the clinical presentation in many of the patients. And this is what we see quite frequently. Many of the patients, they come in that condition. Parabolical subcutaneous metastasis also. Over the abdominal wall, there could be metastatic lesions, which could be quite late signs as such. The grading of the pancreatic tumor is based upon the size and its invasion. So T1 is when the size is less than 2 centimeter. T2 is it's more than 2 centimeter but doesn't invade the nearby cells. T3 is when it invades into the duodenum, bile duct and major veins in the peripancreatic tissue. T4 is when it invades stomach, spleen, colon or so on. Majority of the patients whom we see in the clinical practice, they are seen in T3 or T4 stages. T1, T2 stages diagnosis is not so common in our situation. The other way of grading also would be based upon the size as well as the invasion, the same issue, or it also may be considered as with the stages like stage 1 where it's considered to be resectable. This is from the surgical option. Stage 2 is resectable, but it also has a borderline resectable, either it could be. Stage 1, 2B also is resectable, but again borderline resectable. Stage 3 and stage 4 are unresectable. So based upon the possibility of the surgical option and because of the invasion of the tissues, they are graded by as stages, and stage 3, stage 4 are usually considered to be inoperable. Or the other way, another way of grading these tumors would be histopathological conditions, where based upon the histopathological observation, if there is a significant mutation that suggests you of invasive carcinoma which tends to spread rapidly, where again surgery is a poor choice, you have to go for the chemotherapy. So that's how the decision is made, and the surgical options are again quite rigorous. You have to do Whipple's procedure where pancreas as well as the duodenum has to be removed with the pylorus maybe sparing or non-sparing, which is a very rigorous surgery, or total pancreatectomy or distal pancreatectomy or chemotherapy as such. With all the best possible options now, the latest data is relative 1 year survival period of patients with pancreatic cancer is only 28%. That's the latest figure, which is compared to the earlier days like 75 and 77, it was 3%, now it has been raised to 28%, and overall 5-year survival rate is just 9%. So that shows the prognosis with all the very sophisticated, I am not going into the detail of the choice of chemotherapeutic drugs, but with all that available chemotherapy drugs, with the advanced techniques of treatment, the outcome is still poor. With this, we will conclude about the pancreatic disorders. The next we will discuss about the small intestines and the large intestinal disorders. So we will wind up today. If there are any questions, we will try to answer and then wind up bit early. Right, there are no questions, so we will close today. Right, thank you.